Good evening, everyone. I, I welcome you all on behalf of Acp India Chapter. And today we are here again for a very exciting session of Acp India case files. And we have very good and eminent faculty with us. And to welcome the faculty and to introduce the program, we have Dr. Narsingh Verma. Dr. Narsingh Verma is the secretary of Acp India Chapter, and I will request RX team to please display his introductory slide. Let me just tell you about Dr. Narsingh Verma. There is not, I don't know there is any organization in which Narsingh Verma sir is not active and is not heading any, is not heading the organization. But he is a great academician as well as a great researcher. And he has been at the forefront of many research, many conferences, many organizations. And he is also the professor of physiology at the King George Medical College, and it is always a pleasure to have him. I welcome you, sir, as a secretary of Acp India Chapter, and I will request you to please say a few words about the program and start the program.
Thank you, Amit, and I welcome you all for this program of Acp India Chapter, which is aimed for the early career physicians. And I'm very happy. The agenda of this program is excellent. Very important topic, which is very rarely discussed. Daily we see the patients of fever and also having jaundice. And most of the time, the doctor, patient, everybody is confused. And to clear all these doubts, we have with us Dr. M. Mukhpran Prabhu. And similarly, managing physical activity during a busy practice, especially for a young physician, early career physician, is very important. Because most of the time he thinks that his world is only patients.
Okay. So
sometimes he realizes that his own health is also very good. Indian doctors are very poor in this. They never think about themselves. They always think about society, think about patients, but never think about themselves. So today we have very important topics to discuss, and they're very important for early care physicians. And I'm very happy Dr. Amit Gupta has planned this excellent work and excellent presentations for today. And we have very eminent person to guide us and through us the journey. And as a moderator, we are very happy to have Dr. N.K. Singh. And I will request the RX event to present the slide of Dr. N.K. Singh. Although I know him very well, but still I will like to read the slide. Dr. N.K. Singh is known everywhere because of CME India. And he's a very avid researcher and a very keen clinician. Apart from that, he's a diabetologist, physician, director of Diabetes and Heart Research Center, Dhanbad, chairman RSSGI Jharkhand, and ex-governing body member, National API, ex-chairman API Jharkhand, edited Millennium Book of Medicine and over 30 national and international publications. And it is admin and founder of CME India WhatsApp group editor and editor www.diabetesdhrc.com. And he has several fellowships, including WHO Fellowship of Diabetes India. So I will not take much time because today's agenda is very exciting. I will like to hear. And for that, I invite Dr. N.K. Singh to unfold the various mysteries of fever, jaundice, and the physical activity and all these. So our moderator, Dr. N.K. Singh.
Thank you very much. Good evening to you all. Dr. Narsingh Verma, so close to my heart, and Dr. Amit. And here Manohar is also. And I think I am interacting for the first time with Dr. Prabhu. Yeah, Mukhya Prana, but I have heard about you. So I think Dr. Verma has told that we have two exciting cases of the clinical medicine. A bit about Dr. Prabhu, that he is a professor and unit head, and rather you will be happy to know that he is also a lipidologist in the Kasturba Hospital, Manipal, working as academic coordinator for International Medical Student Exchange in the Mary Place, I think this university, Netherlands, just as it is displayed. And publications 114 international and 16 national index journals, so many conference presentations, so many awards, and luminaries as a very important, having some membership like IAPI, IMA, and Critical Society of India, and also a member of the that is the American Association of Clinical Endocrinologists. So as Dr. Verma was saying, that Dr. Prabhu will present a very exciting case, PUO, that is the paraxia of unknown origin, and having jaundice, and I also think that some pancytopenia, as Dr. Amit sent the details. So first we will hear from him, and then we will discuss the different aspects of this case. So Dr. Prabhu, please start your presentation.
Thank you, sir. Thank you. Good evening, everybody. Thank you, sir, for the nice introduction. I would like to thank Acp India Chapter, Dr. Anuj Maheshwari, sir, Narsim Verma, sir, and Dr. Amit Gupta for giving me an opportunity to present a case in this form in young career physician. Today I will be presenting an interesting case. 1 minute, I will open my slides. 1 minute. Am I visible and audible?
Yeah. Very
so
well.
I will just open my slide. It's not coming.
Yeah, share the slides.
It's visible? No,
I will just share the slides.
Yeah, I will just open it. Yeah, because share option. Yeah.
The share option is below. You can see.
Yeah, share. Yeah. That's, now, is it visible?
Yeah, it is coming, I think. Yeah. So you just start the slide. So yeah.
Is it visible?
Yeah. Just from the,
is it in the slideshow mode?
No, you have to just start
You
from
is
very
it
visible now?
Yeah, fine.
Good evening, everybody who's joining for this interesting session. We have got 2 sessions. I will be trying to finish the case in 20 to 25 minutes. So let me begin my presentation with the quote from father of modern medicine, William Masler. Humanity has 3 great enemies. We know that fever, famine, and war. Now that Russia and Ukraine are in war. But of this, by far the greatest enemy for the humanity is fever. All of us agree, physicians see challenging case of fever, how much difficult to diagnose and treat it. Let me begin my case presentation. So we had a patient who is a 19-year-old female, unmarried, pursuing graduate degree. She was nil premorbid. Her chief complaint is fever for 20 days, but actually she was referred as a 1-week fever. But later we got histories of she had used to have some fever since January 2nd week, and abdominal pain for 5 days and jaundice for 2 days. So if you see the fever history, she had a very high grade fever, intermittent, more in the evening. And initially we went on inquiring her history. She said she had a small fever between some 20 days back, but it was used to subside and treated by the local practitioner with paracetamol. It subsided. And meanwhile, they did COVID test because of the pandemic. It was negative. Later, in February 1st, she had a very high grade fever. She was admitted in the local hospital under a physician. He did routine test and he was found to have enteric fever when the viral titers were high. He was started on treatment with ceftriaxone and azithromycin. Few days of fever subsided and she was discharged on February 7th. Fever subsided, patient went home. Again she had a high grade 104 temperature. She came back to the physician. That time for the 2-3 days, she started developing abdominal pain. Abdominal pain was diffuse all over the abdomen. It was a aching pain and it was intermittent, not classically fitting into colicky abdominal pain. There was no radiation of pain. and there was not related to food. There was no history of any abnormal bowel movements or urinary disturbance. Then just before coming to the hospital, that is February 8th or 9th, she didn't notice, parents noticed that jaundice. So immediately they rushed back to the hospital. One day back, she was discharged. She came back with a jaundice and fever, very high grade. Patient also noticed there is some yellowish discoloration of urine. There was no change in the stool color, and there was no itching or bleeding parameters. Again, she went back to the same physician who had treated her as an enteric fever. He saw the patient's reports at that time. He noticed that patient has got a pancytopenia, hepatitis. Then immediately he referred it to our hospital. At the time of clinical examination, that is on 9th February, she was admitted in our hospital in emergency basis. She was thinly built female. She was conscious. She was giving history, but she was cooperative. But she was quite febrile at 102 to 103 temperature at the admission. She had a significant tachycardia, 123. Pulse rate was regular. Her BP was 100/60, and saturation was 98% on room air. And respiratory, she had some tachypnea. And general examination revealed she had a pallor. She had a significant icterus. Our clinical examination at the time of admission, there was no cyanosis, no clubbing. Specifically, we looked for any lymphadenopathy, edema. We didn't find anything. No rash or ulcers were noted. We did systemic examination, fever, jaundice. We did abdominal examination. She had a significant hepatomegaly, 4 to 5 centimeters below the right costal margin. It was non-tender liver. It was soft surface. Surface was smooth, and liver borders were sharp. It was moving well with the respiration. And there was clinically, we tried to palpate. 1% told spleen is there, another person told spleen is not there. It's a clinical examination. And there was no gaudy, no rigidity, no ascitic fluid was noticed. Bowel sounds were present. We did a respiratory examination. She had a trachea in central, and there was a chest movements were decreased both sides. She was tachypnic. Right side more than the left side, there was a decrease in respiratory movements. And there was when we did percussion in the back, there was some dull note and some decreased sounds or absent breath sounds in the right infraclavicular area and infrascapular area. No abnormal sounds and no bronchial breathing in the corresponding area. We did a systemic examination, cardiovascular system. She had a significant tachycardia, and also there was no murmurs, no third heart sound. And we did a neurological, she was conscious oriented. We did a fundoscopic examination as the initial part. No focal neurological deficits were there. No neck rigidity, no Kernick signs was noted. Her lab parameters done outside hospital on third we had, that was hemoglobin was 10.3. Total count that time was 2,900. At the 61% neutrophils, 32% lymphocytes, platelets were normal, and ESR was 98 in the outside hospital. And her investigation done in LFT outside, bilirubin was normal, direct bilirubin was 0.8, but there was some elevation of AST, ALT, and ALP was normal. Proteins were normal, albumin was slightly decreased, AG ratio was normal. And Vidal test was done. It was outside hospital, 1:160 titer, and it was significant. In the typhoid fever, you can get hepatitis like picture. Patient had a high fever. So they started treatment, had treated with the ceftriaxone. And ultrasound done outside showed mild hepatosplenomegaly, mild cholecystitis, and RT-PCR done outside was negative. Because we are going through the pandemic, it was done in the outside hospital, it was negative. Next, we had is it a case of acute febrile illness? Because we were told that she had a 7 days fever. So we thought, is it acute febrile illness with a septicemia? She had a 103 temperature. She had clinically obvious jaundice, significant. She had anemia. Clinically, she had hepatomegaly, which was not tender, but it was quite 4 to 6 centimeters of liver. Spleen was plus or minus. Clinically, she had bilateral pleural effusion, right more than left, with the tachycardia. with these possibilities, we thought first possibility still, because she told that history of fever previously was very mild. So we thought, is it enteric fever, which was treated partially, or 5 days she was treated. And we are in the endemic area of malaria. Malaria is still a problem for us, malaria, because it can cause fever, jaundice. We get a lot of cases of leptospirosis during rainy season. Is it a leptospirosis? We get a dengue fever. Dengue fever with hepatitis is common. Is it a case of scrub typhus? We have got a lot of scrub typhus cases. We have published a series of scrub typhus cases. They present with usually ARDS, but fever, jaundice, and cholecystitis, hepatitis is also known to occur. Rarely we think fever presenting with viral hepatitis, but sometimes rare things can possibly occur. We kept a last possibility of viral hepatitis. At this point, we had taken the history. Patient had on and off fever for 3 weeks. Is it a PO? Infective? We thought possibility of, because liver was palpable, thaw not tender. Is it a liver abscess, amoebic or pyogenic? And some cholecystitis was there noticed. In fever, pain abdomen, and jaundice, there's a Charcot striate. We thought, is it ascending cholangitis causing spiking fever? Any prolonged fever cases, we keep a possibility of tuberculosis. And prolonged fever, we get a brucellosis cases sometimes, which presents like a tuberculosis. And she had a significant tachycardia and enlarged liver. Features of heart failure. Is it infective endocarditis? These are the possibilities we kept at this point of time. But we had to think of non-infective causes also. Being a female, we thought, is it a SLE, Still's disease? Because her fever was very significant, hepatomegaly was there. Is it a lymphoma or hematological malignancies? Sometimes patients take treatment from outside. Drug-induced disease is another thing. Another possibility we kept, is it an autoimmune hepatitis? These are the possibilities we thought in the presence of fever by history by 7 to 8 days. It's an acute febrile illness by less than 2 weeks. But if we take detailed history, she had approximately 3 weeks fever. And our lab parameters at the time of admission, hemoglobin was 8. Neutrophil counts, the total count for 5,000, 86% neutrophils, and platelets were low, 31,000. It had fallen from 2 lakh to 31,000. And there are large platelets. ESR outside was 98, but our ESR was 21. And CRP was significantly elevated, 170. We did the inflammatory parameters. LDH was 835. TROP-T was positive, and NT-pre and BNP was elevated. Renal functions were normal with a 42 urea, creatinine 0.5. Electrolytes were normal, means slightly hyponatremia, 132 and 4. And PT, APTT were prolonged with INR being 2.17 and APTT being 63.2. And urine protein was positive and procal was positive. We did a liver function test at the day of admission. It was bilirubin was 5.25 with a conjugated hyperbilirubinemia. AST, ALT, ALP all were elevated. Suggestive of hepatitis, probably ALP was more elevated. Cholestatic hepatitis like picture. Albumin had come down to 2.1. Globulin albumin ratio was reversed. We did a infectious hepatitis B, C, A, E, HIV were all negative. Blood cultures were sterile. This was the chest X-ray at the time of admission. If you see this X-ray, there is nothing much except probably minimal pleural effusion in the right side and some pleural effusion possible in the left side, but only blunting of this thing. Clinically, we thought there is some pleural effusion, but chest X-ray was almost normal than nothing else. So ultrasound abdomen was got, ruling out the amoebic liver abscess, 15.7 centimeter liver, hepatomegaly was present. Spleen was enlarged clinically, that we had a doubt about splenomegaly. There was no cholecystitis. There was some gallbladder wall thickening. Pancreas, aortic node, and urinary bladder, there was not much significant. No lymph nodes were noticed, at least in the ultrasound. We did a echocardiogram. There was normal biventricular function. Ejection fraction was normal. Some grade 1 AML prolapse, trivial MR, no clot, no vegetation, and persistent protein foramen was noticed. And this was the ECG, significant tachycardia, approximately 150 per minute. And she had also fever at that time. So this patient was admitted to HDU and started on ceftriaxone, possibility of typhoid, because she had already received azithromycin. We didn't add anything else. Tropical fever workup was sent, leptospirosis, Vidal, wheal Felix, strep typhus, dengue, all were negative. And clinically, at the time of investigation, she had a bicytopenia, it was not actually pancytopenia, but you can say bicytopenia, but hemoglobin was, the total count started falling from the day of admission. It came down to 1000. Hepatitis she had, splenomegaly she had, inflammatory markers were significantly raised. Clinically, she had pulmonary edema or ARDS or cardiac failure. Next 2 days, patient started worsening. Chest X-ray worsened. We thought it's a COVID because still we had a lot of cases of COVID. Repeat COVID test was done in our hospital, was negative. But we thought still COVID, RT-PCR negative COVID is there. We did a HRCT. Meanwhile, we did the inflammatory markers. Ferritin was nearly 4000. LDH started going up. CRP was going up. This was the X-ray which we repeated. First X-ray was showing, this was the first X-ray. If you see the second X-ray, she was developing already either pneumonia or ARDS clinically. She had a started developing significant hypoxemia. So you can see the X-ray on 9th, it was almost normal. 12th X-ray showed bilateral shadows, more in the right side with pleural effusion plus or minus consolidation or pleural effusion or ARDS, you can say. We went ahead with the HRCT. The HRCT was report. There was nothing much in the lungs. There was a moderate pleural effusion in the right side, mild pleural effusion in the left side, and there was some small area of consolidation in the right upper lobe, which I have marked it here. Significant pleural effusion, only patch of consolidation probably, which we could have easily missed. Then we went ahead with the ultrasound guided pleural aspiration. We thought aspirated about 150 ml of yellowish fluid. Again, we had a lot of confusion with regarding the pleural fluid. Patient had a glucose and all biochemical parameters were suggestive of transudative rather than exudative ascites, exudative pleural effusion. It was not fulfilling the Lights criteria. WBCs was high, but again 97% neutrophils. ADA was low. Lymphocyte-rich effusion was there. AFB and gene experts were negative. Again, we were stuck up. We are not conclusive. Pleural fluid was some part transudative, some part exudative, not fitting into Lights criteria. We thought, is it a mod sepsis? Source of sepsis, we don't have blood culture, pleural fluid, all negative. Sputum, she was not getting much, but whatever we sent, negative. Manto test, negative. Autoimmune, we had sent a profile, ANA, global, ANCA, all negative. We were wondering whether we are dealing with malignancy or lymphoma because bone marrow, or should we go with the PET scan? We performed bone marrow studies at this stage. We got a bone marrow report, which was very interesting. Bone marrow aspirate showed significant hemophagocytosis by macrophages. You can see the picture here. I will show the bigger picture. Yeah, this showed that this is the macrophage which has got a, I think my, okay. Erythroid precursor, platelets. This time the platelets had come down to nearly 20,000. Leukocytes had come down to nearly less than 2,000. There was significant macrophage activation was seen in the bone marrow. There was no abnormal cell. What we thought, is there any lymphoma which we had missed, was not there. So bone marrow showed, biopsy showed clusters of macrophages with foamy cytoplasm and hemophagocytosis. It was reported normal cellularity, but good number of hemophagocytic histiocytes. They gave the diagnosis secondary hemophagocytic lymphohistiocytosis. Correlate with the viral studies, CMV and EBV and HSV. We sent all those things. Bone marrow cell biopsy, no abnormal cells, no granulomas, and background shows few foamy histiocytes. You are wondering, she has got a HLH with a cytokine stop, CMV, EBV, HSV, all were negative. We reviewed the HRCT again with the radiologist. They told there is some possibility of some right upper lobe consolidation, bilateral pleural effusion. Pleural fluid is not consistent with tuberculosis or heart failure. Sputum cultures negative, upper zone focus, is it a tuberculosis? And sputum for AFB gene expert is negative. So bronchoscopy we thought we will do. Any comments from this point of time, sir? Yeah,
Dr. Prabhu,
yeah.
So far you have presented it very well.
Okay, so I have shown the reports of the bronchoscopic fluid. Because of the time constraint, I am little going faster. Neutrophils, 88% lymphocytes. Again, AFP is negative, fungus is negative, fungal culture is negative. All three reports negative. Again, we were stuck. We don't know what we are dealing with. But after 2 days or next day, we got a report because they had a doubt. Gene expert was positive for Mycobacterium tuberculosis, low titers. They are so told, right? And rifampicin resistance not detected. So is it a pulmonary tuberculosis? Is this patient has got HLH or is the TB the trigger for HLS? So criteria wise, fever, she had more than 104. Clinically was present. Cytopenia, she had got hemoglobin 8.1, platelet 31,000, total count nearly 2,000. Hypertriglyceridemia, her triglyceride levels were 470. Fibrinogen levels were decreased 137, and bone marrow showed evidence. Again, we didn't do the NK cell activity because we had already 6 out of 9 criteria to meet HLH. But is it a HLH primary or secondary? Is it due to tuberculosis? We are again stuck at that point of time. This was the fever pattern. This was, we could not take a picture, which is drawn by our postgraduate. Her fever used to be up to 104 even every day. Then we started initially piperacillin tazobactam. Because of HLH, we added steroid dexamethasone. Again, fever started going up. Then we got a ball fluid, gene expert positive. We started ATT. Again, fever started going up. Then we were wondering steroids and the ATT. That case problem with the ATT here is the patient had significant jaundice. We started only modified ATT in the form of ethambutol, levofloxacin, amikacin. Then we added IVIG. Again, after 1 or 2 days, fever went up, then started falling. Because of some deterioration, we added meropenem here because patients put a ball fluid grew Klebsiella also. So at that point of time, we were wondering, is it a tuberculosis causing problem or is it a Klebsiella pneumonia? So it was sensitive to meropenem, we added that. Bone marrow aspiration showed HLH, steroids were continued, and HRCT showed right pleural fluid aspiration inconclusive. Bronchoscopy, gene expert positive, modified ATT, levofloxacin, amikacin, ethambutol were added. As tuberculosis is immunosuppressive, we were giving it steroids also. We are not giving full ATT. We took infectious disease specialist opinion also. That's the reason we started IVIG. We gave it for 5 days. And meanwhile, we got another report which showed Klebsiella is positive, sensitive to meropenem, piperacillin partially sensitive. We added meropenem also. Then after 2 days, fever started coming down and inflammatory factors started improving. So again, we didn't know whether it's a tuberculosis or Klebsiella. We did a CT scan of the whole body. It showed that now that we did CT scan, it showed a multiple granulomas in the liver, spleen, and also we thought that it's now the CT scan was reported by the radiologist as a disseminated tuberculosis. So if we went to at this point of time, any comments, sir? Because we were giving patient had a bilirubin significantly high. We had a disseminated tuberculosis. Patient had a HLH. We were giving steroids. Again, we went through the literature. Tuberculosis is not a common cause of HLH. It's very rare to cause HLH and it's unusual. If we saw the literature review, less than 100 cases of HLH have been described as a disseminated tuberculosis. And we had also Klebsiella pneumonia. We also went through the literature. There are very few case reports which showed Klebsiella as a cause of disseminated tuberculosis. In this patient, we had a 3 weeks fever. There was no cough, pleural effusion, not a exudate. So, but again, ball fluid was positive for gene expert. We thought it must be still a tuberculosis. Additional infection is a Klebsiella. So then our lab parameters, she had a platelet started improving. CRP came down to 30, LDH came down. Bilirubin was significantly high. Again, this point we had a therapeutic dilemma. Should we give ATT? Patient is sick, but improving in other parameters, we are giving a steroids. ALP was 629 at this point of time. Again, this is another challenge for us. What to do? Treatment of ATT, we are giving only levofloxacin, ethambutol, amikacin. We are not giving any rifampicin, INH, and pyrazinamide. There are so many articles how to treat the patient with tuberculosis in presence of hepatitis or hepatic failure. Again, patient has got a treatment with the dexamethasone for the HLH. What is the problem when we treat with the steroids? So I think I have gone through fast because after 20 minutes was given for me. And any discussion, any part is there, you can give, tell, or anything else you want to tell. Please,
well done. Well done, Dr. Prabhu.
Yeah.
It was a very, very challenging case. And I think you have given a very important message that whenever some patient is coming, basically three things as you told, the prolonged fever,
Yes,
then there is pancytopenia,
yes, sir.
and I think the three presenting features and also the hepatosplenomegaly, cytopenia and prolonged fever, we should be aware that we should go to think in line of hemophagocytosis, which beautifully you have shown. This is a pathologic findings of activated macrophage engulfing the erythrocytes, leukocytes, platelets, and the precursor cells. I think this is more hard in the pediatric group of cases.
Yeah, yes.
But even some Kala-Jar cases, this has been reported, but
Yes,
I have not seen
Yes.
someone presenting with this problem with the tuberculosis. But anyway, I think that the most probable diagnosis at present, it is due to the tuberculosis, but challenges already you have shown regarding the ATT and steroids, but how the patient is responding?
Patient is clinically better, sir. Now the today's bilirubin is 6. So I am thinking of reintroducing INH by 75 milligram from Monday. I have come down on the steroids. We are giving now 6 milligram of dexamethasone twice daily. IVIG course is over. We are continuing ethambutol, levofloxacin, and amikacin. Now I am thinking of introducing INH next week. I have had a detailed consultation with our gastroenterologist. If there is no major granulomatous hepatitis causing a CBD obstruction, he said you can start, but you should go very slow because otherwise patient may die due to hepatic failure rather than tuberculosis.
Dr. Prabhu, one question is in the chat box by,
Yes,
I
sir.
think, Dr. Praveen.
Yes,
Is
sir.
it HLH or just hyperferritemia associated with mass or mods as CRP is significantly high? So what do you say about that?
No, it's a clinically she has got a fever, inflammatory marker, what you say, cytokine storm, very high ferritin, very high triglyceride, and also very high ferritin and inflammatory markers. Bone marrow, because there is a pancytopenia, we did a bone marrow to rule out lymphoma or tuberculosis because lymphoma is one of the causes which can present like that. It showed significant hemophagocytosis, which was very classical. I have shown the bone marrow pictures. It's a very classical.
Yeah, I think Dr. Praveen, it is quite clear when the bone marrow has already picked up the case. So it is LH itself. And what is the cause of that?
Yeah,
that is being discussed. But at
Yes,
present, I will agree. And if Dr. Amit or Dr. Burma have any comment, otherwise we will proceed for the next case.
Sir, one more, I want to acknowledge my medicine resident who did help me in presentation, Dr. Alaikya and other PGs, because it was a tough case. They had also tough time. And the clinical hematology department were giving me very good pictures. And they said that it is a HLH. That is also very important for us. HLH is a disease of childhood, genetic, hematological malignancy, SLE and all. But we had a challenging case due to tuberculosis, the disseminated tuberculosis, microbiology department, radiology department. These are my references. I want to end my presentation by again William Osler. Medicine is a science of uncertainty and the art of probability. We have to think common diseases first with common presentation. Here we had a disease, common disease, uncommon presentation. Next is common disease presenting as uncommon, like tuberculosis. Here is a HLH, which is a rare disease presenting like a common disease. So we had two diseases. HLH is a consequence of disseminated tuberculosis. Thank you for the opportunity to give on. Anybody has got any comments, sir? Amit Gupta, sir, or Narsingh Verma, sir, you can tell.
Amit, any comment? Because he had done very well and given a very clear-cut message.
I think you have found a very good case for presentation in CME India website also. I think Dr. Mukhya Prabhu can send it to you.
Yeah,
And,
yeah, I will just, I'm going
we
to
can
request him.
we can put it on behalf of Acp India chapter so that a lot of people are able to watch it later also along with the video. We can do that.
Yes, sir.
And excellent presentation, sir. And this is what we expect from a highly, what I say, highly great academician like you. And you have really nailed the case. It is good that you have found the diagnosis. And this is the beauty of the medicine, what you have highlighted, that every case is different. Every case is a challenging case. And this is how, where your knowledge comes into application. Nursing Verma, sir, your comments on the case.
Yeah, definitely. It was an excellent case presentation by Dr. Mukhya Prabhu, and very clearly said, and the lesson the early care physician can learn. What happens when a fever, a patient comes and fever does not subside, then the physician becomes nervous. And most of the time what happens, I'm not talking about an institution, I'm not talking about the medical colleges, I'm talking about the early care physicians. They get nervous and they keep on changing antibiotic to antibiotic to antibiotic to antibiotic. That should not be done. One should try to find out the cause, try to make diagnosis, what Dr. Prabhu did in this particular case. And he was having support so that he was able to do that. But in a clinic, it becomes very, very difficult to diagnose these type of cases because the patient also become anxious that my fever is not going down. And that makes a lot of pressure on the early care physician or any physician, and then starts the jumping from this doctor to another doctor to another doctor. But in this type of cases, one diagnostic dilemma is already there, and it is very, very confusing. Most of the time when patient of fever comes to us, and when we go for investigations, I advise that all investigations should be done at least 5 to 7 days after the occurrence of fever. Why? Because all the immunoglobulins which we are trying to test will take at least 7 days to be formed. So fever today, fever, and next day you go for all investigation. You will not make a diagnosis anytime. And the problem starts when most of the time in viral fevers you will get Vidal positive, you will get dengue positive, you will get everything positive. So that makes a diagnostic dilemma. And most of the time, viral fever present like that, everything is positive, including malaria. So that requires a lot of caution. Excellent case presentation. I congratulate Dr. Prabhu.
Thank you, sir. Thank you for the.
Yeah, you can stop sharing.
Case. Patient had a 104 fever, and again we had a tough time because patient was deteriorating and going into hypoxemia. We thought that we might have lost her. Thank you, sir. Thank you for the
excellent, Dr. Prabhu. Can you now stop sharing the screen?
Yes, sir. Yes, sir. I'm stopping it. Yes. Yes. Thank you, sir.
Yeah. So now the next case, how to integrate physical activity in the busy professional life, by one of the very close friend of us, Dr. Manohar Kane. So everybody is, I think, knowing him. He is at triple FRCP, you can see, and he is MBBS from the KMC Mangalore, clinical examiner for the MRCP UK. He is organizing secretary, KRSSDI 2017, chairman reception committee, EPICON 18, and recipient of excellence in diabetes care, many awards, rising star in diabetology. So I have great pleasure to introduce him and ask him to present this very, very important and relevant topic that is by Dr. Manohar. Is an expert on that, I believe. So Dr. Manohar, can you start?
NK Singh, sir, I will just like to highlight that Dr. Manohar is not going to share any presentation. And we are going to, this is a chat session where we are going to talk to him and how he is including the physical activity in his busy professional life so that we all can learn from him. So Dr. Narsingh Verma, sir, Dr. NK Singh, sir, all of you are free. What we have got is that we have got some photographs, some videos of Dr. Manohar, which we will be playing in the session, and which are showing that how seriously he is engaged in physical activity. He is actually not just speaking on the subject, he is actually doing that. So
Yeah,
this is
Amit.
the idea which was suggested by our governor in the last meeting, Dr. Anuj Maheshwari sir, that better to bring him on the platform because he himself is an ambassador of the physical activity. So we thought that,
Yeah,
yes,
yeah.
sir. So please go
I
ahead and
think,
you can start with your first question, and we will in between.
Yeah. So this is also a big thing that he is not sharing anything on the screen. But I think he's a role model. He is not only preaching about the exercise. I have, as you know, that he's also a marathon runner. So he knows the art and science of the exercise. Because science, most of us know, but the most important question today, as far as the professional life is concerned, the art, how to implicate the art in the exercise. As in the ADA, many times we have heard, there are so many benefits of exercise. Everybody knows. You can enumerate hundreds of benefits. It is also has been stressed that exercise not only brings the benefits in future, but if you do it today, you will get the benefit immediately. Today itself. Still, the most important question is, when there are so many benefits, rather Phil Sutherland, of the director of the Novo team type 1, says it is $1 million, billion, whatever you say, the $1 million drug, which you do not do. So Dr. Manohar, first say why people are not motivated to do such a wonderful thing.
Yeah, firstly, I would like to thank ACP and all those kind words. I've learned a lot from CME India NK sir. Most of my slides on exercises, knowledge, which is very, very important, is come from him and his groups. So thank you for that. As doctors, I always feel we read a lot about pathology than physiology. We read a lot about illness than wellness, isn't it? So wellness possibly that too more to learn what is happening than how to make it happen in physiology and the first years of medicine. So somehow we get like the famous adage that poor doctors treat complications, good doctors prevent even the risk factors, or primordial prevention, if you want to talk about it, or primary prevention. So learning is definitely mutual. So especially thanks to this opportunity for early care physicians, especially because if we don't inculcate early enough, we will not be doing well in the later part of life. So the question was about fitness. If you really look at even Bhagavad Gita says the only lifelong companion we have is our own body. It is not any friends or family members or our profession or whatever. So I always tell this, love yourself firstly and take 1 hour out for your own self. Don't share that 1 hour with anyone, especially your patients, especially your close family members also. So 1 hour you do what you want. You want to relax, you want to think further, you want to exercise, you want to listen to music, or you do whatever you can. So that is where it started. I'm a nerd. I was always a nerd. I was either studying like most of the doctors, of course. So either I was studying or working. So it's a long time since my mom kept telling me that you don't practice what you preach. So it all changed. One day I was supposed to give a diabetes symposium and I was told to talk about diet and exercise. So it started hurting me more when I was trying to make slides myself. And then I thought, okay, at least I should do something. So, and then I had few friends around who were running. And so I joined that running thing, started coming to me. And that's how it started. So love thy workout as thyself is what I always tell. And the most important relation what we have in the world should be with our own self. So that is the two important things I inculcate and follow when I talk about exercise.
Dr. Manohar, I will request Kundan to show some of the photographs of Dr. Manohar. And I will ask Dr. Manohar that at what age you started doing regular physical activity so that our early career physician members, they understand that how important it is to start early.
Well, I think ACP chapter of India has made me like a celebrity. So I didn't expect my videos and photos will be flown. Actually, recently, some 2-3 fitness groups approached me for being their model. So I was very surprised. I don't have a six packs. Neither I've done. I'm not like a Bruce Lee like figure also with muscles everywhere. So why people wanted me? Possibly, I feel that maybe if you show someone with six packs, you may not relate yourself to them. So if you see a doctor, of course, everyone are busy, and I see many more busier than me, and having reasonably okay physique, maybe people can relate better to him rather than anyone else. So as I said, my running journey was not too old. It was in May 2015, I did my first 10K marathon, 10K run. So only in early 2014, late, I started doing some physical activity consistently. Of course, in younger age, we get hyper and see someone and go to gym or do some runs or workouts for few days, and then you leave it at that. So first, I did my run, 10K Nike run, it was called, in 2015. And then the TCS 10K run is a gold standard run for Bangaloreans, at least for 10K. So I did it in 2015. So I did my first half marathon in 2016. So within a year, I could do it. So after that, I took another year and did my first full marathon. Of course, I would like to acknowledge that there are many more people who have done much more fitness related activities than myself. And most importantly, some two groups I keep track of. One is the CME India group to learn medical knowledge. The other is a lot of fitness groups I'm a part of. So this group is very, very important to keep us motivated. So I always believe in one thing. Fitness is not that we ran a full marathon or having six packs. And fitness is also not just the workout, what we do for 1 hour a day. So there are many people who do outstanding workout for 1.5 hours. We don't see any results there. Because remaining 23 hours, what you do also becomes very, very, very important. So if you do workout and then you are like a sloth throughout the day, then it is not going to help. We all know sitting is the new smoking, and mobility is the key. Like I work in a very big hospital where there are 11 floors, and 9 out of 10 days I climb the stairs from -1 to 11th floor. So, and even I get dropped at the entrance of the gate and I just walk around. So these important things can be inculcated, because we always, as doctors, we say we are very busy. So if you don't look after yourself, you will not be doing justice to your patients. Many instances, just now I saw a patient who was quite very obese and who told me that I see you running, and now I also want to join you. And there are other instances where some people have taken up to running or different forms of exercise, and they won much more medals than me, and they've shown to me. I usually show that photos whenever I'm giving a talk in any conferences. So that's how the journey is. First is we got to be motivated. We need to think, we need to practice what we preach. Secondly, we should keep the motivation up and do different type of exercises. See, there are something like what I see from some others and learn, but when you start the journey of exercises, my own submission is, when I started running every day almost. So I used to visit physiotherapy department as much as I used to visit my own department. Means I used to get injured. So these are the challenges what come, and how you overcome the injury will make a lot of difference to your mindset. Sportsmen are definitely different people. One other instance I would like to share, like many times I got injured, even now I'm just recovering from a hamstring injury. One time I did the Mumbai monsoon marathon. So Bangalore is a beautiful place, very good weather, but you can't extrapolate what you do in Bangalore at Mumbai or anywhere else. We see cricket teams struggling abroad or any other state when they go to play, because of the pitch is different, weather is different. So I almost like passed off after doing the half marathon. So it teaches us so many things, and it gives a definite high also. Runners high, workout highs also are there, and it motivates everyone else in the house also to do workout. So my kids start playing and jumping around and start running on the treadmill. So that it sends positive vibes everywhere. So that is the most important aspect of it. And especially exercise, as I said, don't be repetitive. It should be mixed. I'm sure I don't want to bore with the ADA guidelines and other things. Resistance training is important nowadays. Endurance is important. Flexibility, balance. So all the four minimum you should inculcate in it. Don't try to do the same thing. You will get injured also. And there's a famous saying that some activity is better than no activity. They always say, do not sit if you can stand, and do not stand if you can walk, and do not walk if you can run. So this year, two things I have done. I told Dr. N.K. Singh, one is to eat early dinner, and sir, I'm successful in it. I'm having my dinner at between 6 and 6:30, and then I come to the clinic. Second thing is I sit in this clinic for maybe 2.5 hours. So instead of using the easy chair, now I have moved to the Swiss ball or the yoga ball. So this gets my posture corrected. So this I'm doing from Jan 1st. And this has made a lot of difference in me. To have dinner early, my acidity issues are gone, and my posture is tremendously improved by sitting on this. Of course, it requires, I face some issues. If someone wants to go all out like me, they can contact me. I'll tell them what are the challenges which come and how to go about it. But there's minor things what we can do, especially going up and down the stairs is very, very important. Even at the end of the day, you should try and do it. I will promise you will reach your destination earlier than waiting for the lifts, and you'll still feel more energetic in spite of the mask I'm talking about. So these are some things which I make small differences in that workplace.
I think this was a great message you have just given by showing that the yoga ball. I think it is not a yoga ball.
Yeah.
So you have stressed the importance of both the aerobic exercise, the flexibility exercise, and basically the endurance or resistance type of exercise, which is so important these days. Can you say to our physicians who are so, because what you are doing is something extraordinary that every like Amit cannot do, or I think that Burma is doing too much. I am not aware about what Dr. Prabhu is doing, but what to do for a general physician out of so heavy, suppose they sometimes they are working for 8 to 10 hours or 12 hours. So how to basically motivate those persons who don't have much time? So can you give some tips for that?
So the biggest myth in life is we don't have time. Okay. First is stop that wrong notion. One message I would like to give here is in the 5th decade, 45 to 55, if you look at it, the most common professionals to have myocardial infarction is medical professionals. Yeah. So if you don't have time for yourself, make time for yourself. We find it very difficult initially, especially early care physicians. I could have gone and practiced there. So whenever some people meet me, I tell some clinic or some point of work, you leave it. Okay, so it may not be very easy, as you said. So I always tell, love yourself. 1 hour a day is yours. Secondly, fitness is not just doing exercise. Nutrition, very important. Physical activity is not just exercise, what I do, workout or whatever, but as I said, interrupted sitting, using stairs, walking as much as we can is very important. Sleep and mindfulness. These are very two important entities, because even we have seen a lot of people who exercise succumbing to cardiac illness. Mainly when we look at their activities, if I'm overstressed on a day and when I get up and I don't feel rested, I won't exercise. I give up. I will tell my trainer, it's okay, today I will not exercise. It's fine, because there are many people, even the famous film actors we have seen, that they party or work till late night and get up with the improper sleep and start doing the workouts. Because sometimes this workout highs or runners highs is a problem also. We always talk about mind over body. Mind, of course, is placed over the body, but you should listen to your body also. Get up, don't feel fresh, don't work out. Secondly is mindset. It's a famous quote that mindset is the difference between successful people and unsuccessful people. So you got to change our mindset and give time for ourselves and discipline. So mindful eating, exercise, sleep, all the ingredients should be encompassed for us to be successful in exercise. It's not just you do something and you think you are fit. I'll be honest in my acknowledgement of how poor I am with respect to fitness. I got recently evaluated by people. I'm very good in my endurance. I'm very good in my aerobic, anaerobic thing. But when it comes to flexibility, I'm very, very poor. So we should always encompass everything, and we should have a reward for ourselves, running something or going out with friends and participating in an event, having our groups. I've seen a lot of cycling groups, runners group, hikers groups, very, very important. Swimmers, there are Ironman. There are many doctors who have done Ironman. I'm not dared to do that yet. So we should feel happy about what we are doing, and we should first look after ourselves and be role models. That is my main message there.
So do you recommend that suppose we don't have time in the morning, so do you recommend any specific time, suppose in evening time or afternoon exercise?
Yeah, I think you have spoken extensively. I've heard a lot of your talks on
that. That is okay, but today you tell what is your opinion?
Yeah, my opinion is time and place, unfortunately, can't be same for everyone. It's easy for me to say 1 hour you take out, but you take out in the morning or in the afternoon or in the evening, should not be a problem. What I would say is, of course, you should not have had meals at least 2.5 hours before you start exercising. Okay. And you should have a restful day. You should not be stressed out and start exercising. Already the adrenal surge is high. Or if you had COVID or any other infection, again, you should follow the disciplines. I intend to run one more full marathon. So I did all my health checkups. I did my CT coronary angio also, because I was scared when I was doing, I had some minor doubts whether this chest pain is this thing. So we need to take care of ourselves also. Because we had a recent incident, one of our colleagues who is younger than me, recent COVID, was scrubbing for a case, a neurosurgeon, and he just collapsed. We don't know what is the cause. But if someone else was there, if the same as a different patient would have consulted us, probably we would have told you do this test and do that test. But for our own self, do we really do it? Many places it is said doctors are poor patients when they get to illness. So we should change that mindset. Of course, patients are important, but I think we are much more important than anyone else for ourselves and our close family. We can't be replaced. If I am not there, they will see someone else tomorrow. That is okay.
I think, do you have any aware about any study regarding the using music during exercise or during run? Because I've seen many runners have some musical instrument, thing playing in his ear. So do you have any better effect it brings down or brings or not? That can you say?
Maybe if you know, you can tell that. But I always tell one thing, especially in our country, when there are no dedicated lines for exercise or cycle as yet, in few places it is there, putting music and running could be dangerous also. Yeah. So I am a bit very scared to do that unless you're doing it in close surrounding and place is secured. So please don't do that on any street or something which we usually end up running. I don't have time. So what I do is, there are people who go to exotic places and run Kaban Park, Lal Bagh, one university campus and things like that. But I have my limitations. Even Sunday I might have to go for rounds. So I open the door and I do some stretches and start running there. So I discourage music in such circumstances. But otherwise, definitely when I have done indoors, music is a great thing. Sometimes we watch some documentary or something, also do the exercise. It gives a different feel for us.
Yeah, I think that is the answer. Only thing I have just come across a study done from the US that while doing this Surya Namaskara, when they did it with the mantras and music, it brought too much beneficial effects. So that is documented in the science itself. So that is the one information I would like to share. Dr. Burma, what is your opinion or any questions to Dr. Manohar?
I think Dr. Manohar has very clearly given the insight that you should love your body. And once the physician or doctors start loving themselves, then the problem will be solved. And there is no fit formula for all. We need a different formula for different persons. And the physician himself is the best judge what he can do and what time he should do and what type of activity he should do. One cannot suggest activity for all the group. So I think he has very clearly told that. And I love that he has said that it is a myth that I do not have time. They have time to chat on WhatsApp. 70-80% of physicians are busy on WhatsApp. They can't miss a single message for 10 minutes, 15 minutes. No, they will reply. So they have all the time for chatting on WhatsApp, but they do not have time for physical activity. I will not agree. I can give some tips what I am doing. Because in my town, doctors are most unsafe persons. If I go to outdoor, there are 4 or 5 problems in a park. One problem that everybody recognize me. He want to consult me even at park. Not giving any fees. Second, I can be hit by any vehicle, anytime. Third, somebody try to snatch my golden chain and he may kill me. Fifth, in Lucknow, not in 5 years, but 10 years before, most of the doctors were killed while they were on morning walk. Because that time everybody knows that he will be at that particular time, he will be in that particular place.
Yeah.
In last 5 years, this has not happened, but before it was very, very common. And if 1 hour I am out of my house, then I may miss some important engagements. So what I do, every doctor, every person, I think reads some newspaper. So while I am reading newspaper, 30 to 45 minutes, my legs are on bicycle, static bicycle. So while I'm reading newspaper, I'm busy, my legs are busy doing something else. So those 45 minutes can be utilized while you are reading gossips. Nothing in newspaper, it's still, you can't leave it. And second thing what I do, I had a big campus. So I go by the car, park it at my place, and then whole day I keep on walking from this place to that place to this place. And our this Kalam Center where classes are being held, it is 6th floor. I never use lift. I always go by stairs. And I reach before my students reach by lift. Because in lift there is a capacity. But in stairs you can move. So these are the few tips one can design themselves. Nobody, including Dr. Manohar, can tell everybody that's what they should do because the physicians know themselves. Only they are avoiding it. Nothing will happen to me. They think that they're immortal, but that is not truth. And you're very correct. Most of the time, what I advise to my fellow physicians, and most of the time, when they are overweight, then I say you have no right to practice because you are not abiding to the laws of the health. So if we think in that particular direction, time will definitely come. Automatically it will come.
Dr. Amit, do we have some time or should we wind up?
Yes, sir. We are 8:35. We can wind up. I would just like to make few pointers that what Dr. Manohar has said is that he is a busy doctor. We should look at him that he is going to a very big hospital also. He is running his OPDs also. But if he can take out time, then all of us can take out time. So everyone who is watching this episode, it is a sincere request that it is equally important to take care of your own health. So an ACP India chapter has a particular emphasis on this. So there are a lot of activities which are done for well-being of the physician and their well-being champions also. And it is at the forefront of ACP India chapters. It is one of the mission of the ACP India chapter that each and every doctor should be healthy. So each and every member of the ACP India chapter should be healthy. And this is what, if Dr. Anuj Maheshwari would have been here, he would have highlighted. He had some other commitments, so he could not join today. But Dr. Narsingh Verma sir is here. So he has very excellently pointed out that exercise is very important. Dr. Manohar, I can see a lot of medals behind you. As it is difficult to even count. I think they are 50 plus.
Everything is with respect to non-medical only. It's all running related.
Yes.
Related one.
This
I
is
have to throw it somewhere. So one of the patients told me, why don't you put it there and it motivates us.
Yeah, it motivates definitely.
Definitely in a day, if I see 10, 12 patients also, at least 4, 5 people will ask and 1, 2 will join me that weekend runs. So that is doing a good job of promoting fitness to my general public and the patients. So recently I started one thinking process like lifestyle as a prescription. So lifestyle as a prescription, we should also write for others and we should also keep it for ourselves also. This is one prescription which we need to follow. So love yourself. 1 hour a day is not a big thing. So firstly, you love yourself. Nutrition, very important. Food, how much, what, and when, all three are important. Physical activity is not just the 1.5 hour exercise, but what you do the rest of the day, as Narsingh Verma sir rightly pointed out, is important. Sleep, never neglect it. It's one of the most neglected entity. Nobody talks about it, but that's the most important thing. Mindfulness and self-discipline. So if we inculcate these 5 points, I think we will be a good role model to our patients. And as I said, I don't have any 6 packs to show or any muscular body, but this figure possibly relates easily to patients than someone with those high achievements with respect to body image. Thank you very much for the great opportunity. And I've been a great student of Dr. N.K. Singh and Narsingh Verma. And Prabhu. We know him. I studied in Bangalore, KMC. And he presented a very difficult case. We always say PEO is the biggest challenge to all of us. So I always joke, if you have any enemy physician, you just refer of such cases to them and let them handle it. But he has done a great job with that. And thank you very much.
Yeah, Dr. Prabhu has done a great job. And Dr. Manohar, you have also done a great job by just motivating our physicians. And even we have got some message from the Dr. Verma also. Amit is a very dynamic personality. I think I have no words to praise him. But anyway, he's doing a great job. I think, Amit, we have done a very, very important session today.
Yes.
I would like to end here. That once Dr. Yagnik was telling to me that whenever I go to my hospital, the first thing I do is to stop the lift. So that is again giving us a great message. And my experience is that sometimes I get bored while walking for 1 hour in the morning. In that case, my dog is a great help to me. So he keeps me moving, or rather he keeps me moving all day. So I think there are studies also that dog owners have a better physical activity. So with that, Dr. Amit, can you end with?
Yes, sir. So at the end of this, a wonderful session we had today. And thank you, Dr. Mukhya Pran Prabhu, for presenting an excellent case. We were still getting a lot of comments and I could see you replied in the chat box. And thank you, Dr. Manohar, for being a good, ideal person to be followed in terms of physical activity. Dr. Narsingh Verma, sir, as usual, he will always come out something from the physiology and something from the basic science, which we all miss. We always talk about very high of this and that, but he will easily simplify everything and give it to us in such a way that it is very easy to follow and easy to understand. Thank you very much, sir, and for being here. And Dr. N.K. Singh, as usual, sir, you are always a very good moderator, as you do in CME Meet India, and you are one of the person who is educating each and everyone almost every day. And maybe I don't think there is any time where the CME India group remains silent. So with this, I would take this opportunity to thank everyone on behalf of our governor, Dr. Anuj Maheshwari, for this program. And we will see everyone next month again with another episode of Acp India Case Files. Thank you, everyone.
Thank you, sir. Thank you, everyone.
Thank you, everyone.
Good night.
Okay, good night. So we'll be leaving now.
Good night. Bye.
Tomorrow is Sunday and I hope someone does some activity. It's usually my long run days tomorrow. So I don't party on Saturday night.
Right. Thank you.